Mr. Chairman, ladies and gentlemen, dear colleagues. It's my distinct pleasure to report on time and therapeutic range and frequency in range for those patients in Garfield AF who were treated with vitamin K antagonists. And this presentation again relates to patients coming from cohort 1, 2, 3. These are my disclosures. And the objectives are to show the time and therapeutic range with a predefined INR window, which is internationally defined of INR 2 to 3, not only for warfarin, but also for different types of VKAs used in Garfield AF. And also to analyze the quality of VKA control using two methods. That's the time and therapeutic range, which is most frequently used as quality control in randomized controlled trials. However, in real life, if you ask your physicians, they most frequently analyze the frequency in range. That means the percentage, how often, how frequently their patients were in the predefined target range. So this time, we used both methods for analysis. And last but not least, to analyze the INR-related incident rates of 1-year outcomes. As already said, we only analyzed patients with vitamin K antagonist treatment, but regardless, with or without antiplatelet therapy on top. And the patients were only included when patients with fewer than 3 INR readings were excluded from the TTR analyses, and in case of vitamin K and antagonist discontinuation or also any interruption, all INR readings thereafter were dropped even if the patient resumed VKA therapy. So that is just to set the scene. And here you see the types of vitamin K antagonists used. The vast majority of patients, as expected, were treated with warfarin, more than 60%, but also acenocumarol, which is most frequently used in France and in Spain and in other countries, was on board, and in the German-speaking countries, including Germany, Austria, and Switzerland, where we have the fenprocomone, the long-acting vitamin K antagonist, we have about 8% of the total patient population who received this type of vitamin K antagonist. And here you have highlighted that more than 20% of the patients received double antithrombotic therapy. That means on top of vitamin K antagonists, they also received antiplatelet therapies. In real life, anticoagulation control is suboptimal. This may be the British phrasing. Frankly speaking, we can say it's lousy, regardless of the type of vitamin K antagonist used and also the method of analysis. You see on the right side, the mean TTRs are far below 60%, and according to the NICE guidelines, a TTR of at least 65 or lower than 65% indicates poor anticoagulation control. And you see we are in the range of suboptimal use of vitamin K antagonists for all types of vitamin K antagonists using the time and therapeutic range, and also the frequency in range shows the same pattern. And again, there is no difference between the types of vitamin K antagonists, warfarin, acenocumarol, and fenprocomone. To be honest, we were a bit concerned in Germany because we thought that fenprocomone is more stable for anticoagulation, but it's not true. We have the same pattern, and also it's difficult in using this vitamin K antagonist to achieve adequate anticoagulation control. So using both methods, we are looking for outcome. Here you see the event rates for frequency in range, and we used the cutoff of at least 65%, and for all severe outcome parameters such as stroke and systemic embolism, major bleeding, and mortality, you see that suboptimal control of vitamin K antagonist is associated with significant increase of these negative outcomes. if we use the other method, more frequently used in the trials, as you know, and as already said, you see the same pattern. Time and therapeutic range analyses lead to the same conclusion that suboptimal control is associated with a significant increase of these severe outcomes. So these were the 1-year analyses. That means patients who stopped with vitamin K antagonists were then followed up to 1 year. This slide is the key slide of the entire presentation, because this shows the 1-year rate of stroke and systemic embolism for patients with AF according to the levels of INR. You see on the left side patients with an INR level below 1.5 up to over anticoagulation up to levels of INR and 4 and higher. Well, if you see this presentation or this table, this graph relating to stroke analysis, you say, what's new of that? We know that. We have seen that since the 90s, where Ellen Heilig presented on that under anticoagulation is associated with bad outcome, stroke, for example, and over anticoagulation is associated with bleeding. However, it has not shown so far in this clarity that we are talking about 2 types of stroke. And that is the beauty of the slide. We had 25 patients with stroke in total here on the left side with under anticoagulation, and 24 of those patients had indeed ischemic stroke, and only 1 patient had hemorrhagic stroke. And on the right side, fortunately, we had much fewer patients with hemorrhagic stroke, in total 5, but out of these 4 patients had hemorrhagic stroke, and only 1 patient was with an ischemic stroke. So it is not only plausible, but it is clinically relevant to keep the patient in a target range. And the international target range is between 2 and 3, where we have at least the safest way to use the vitamin K antagonist. So the next 2 slides will relate to other outcomes. This slide relates to major bleeding, and it's very plausible, and it has been shown by others in the past, that there is an increase of major bleeding in the patients with over anticoagulation. And talking about mortality as all-cause mortality as the hardest endpoint, we see a clear pattern that patients with over anticoagulation also have the highest all-cause mortality rates. So, in fact, as already said, that is not completely new. However, we sincerely hope that we will be the last ones to report on the inadequate anticoagulation control with vitamin K antagonists, because I think it is a shame, after more than half a century of use of vitamin K antagonists, still seeing these data in real world. So I'd like to summarize and to conclude. The international guidelines on stroke prevention in AF recommend, as you know, the INR range between 2 and 3 for vitamin K antagonist therapy, although we have local differences, regional differences. As we heard from Professor Goto, in Japan, they have in their guidelines recommendation to not have this target range in general. According to the guideline from NICE, as already said, the TTR of 60% and lower indicates poor anticoagulation control, and unfortunately, this is not sufficiently achieved in routine clinical practice, regardless the type of vitamin K antagonist used. And last but not least, suboptimal anticoagulation control is associated with an increase of negative 1-year outcomes, such as stroke, systemic embolism, major bleeding, and mortality. And therefore, I think time has come for a change in standard of care. Thank you very much.